present an overview of hypertension management. I'll say a few words about the epidemiology of hypertension. As you know, hypertension is the leading global risk factor for cardiovascular mortality and disability in adult women and men. And hypertension becomes progressively more common with advancing age, with a prevalence of greater than 60% in people aged more than 60 years. And it's estimated that the number of people with hypertension will reach close to 1.5 billion this year. And it's the most important modifiable risk factor. And as you know, most patients with hypertension have essential hypertension, while 5 to 10% of patients have secondary hypertension. So the pathophysiology of hypertension is complex. It involves a complex interaction between genetic, behavioral, environmental factors, and socioeconomic and psychological factors, as well as renal, hormonal, vascular, and neural mechanisms. Hypertension ends up in hypertension-mediated organ damage, and if untreated, patients will develop cardiovascular disease. Hypertension-mediated organ damage is an asymptomatic stage of complication of hypertension. So the involved with the complication of hypertension are the heart in the form of left ventricular hypertrophy, coronary artery disease, and heart failure. And patients also develop atrial fibrillation due to hypertension. In the brain, they could have vascular dementia, ischemic and hemorrhagic strokes, white matter lesions, which we see commonly on MRI reports. And they could also develop peripheral arterial disease, hypertensive retinopathies, and in the kidneys, albuminuria, CKD, AKI, and so on. So the most important evaluation of hypertension is to diagnose it accurately. So when we do office blood pressure measurements, we should be very careful in following all the steps, and patients should sit straight with their back supported, with their legs not crossed, and the arm should rest on a bench where the blood pressure cuff is parallel to is at the level of the heart at about the angle of Louis. And patients should not take caffeine, should not exercise for about 30 minutes, and they should be seated comfortably for 5 minutes before the measurement is taken. And ideally, 3 measurements should be taken and averaged. If there is more than 10 millimeter of mercury difference between the measurements, then the measurements shall be repeated until there are measurements which are close to each other. And at least at the first visit, we have to check for orthostatic hypotension, and as well difference between BP measurement difference between the 2 arms. So generally, systolic blood pressure appears to be a stronger determinant of cardiovascular disease risk than diastolic blood pressure. And incremental pulse pressure, and also non-dipping status, which is the loss of the normal 10 to 20% decrease of blood pressure during sleep, and BP variability are associated with higher risk of cardiovascular disease events. When we see hypertension and cardiovascular disease risk, in many meta-analyses, the hazard ratio for coronary heart disease and stroke were between 1.1 and 1.5 for blood pressures of 120 to 129 by 80 to 84 versus the normal blood pressure. And the hazard ratio even further increases when the blood pressure goes up to 130 to 139 by 85 to 89. And cardiovascular disease risk begins below thresholds used to define hypertension, and the risk increases with higher blood pressure levels. So this is a meta-analysis of 61 prospective studies, and we can see that the risk for mortality from ischemic heart disease rises steeply in each age group, starting from a blood pressure as low as 115 millimeter of mercury. And as the blood pressure increases, the hazard ratio, the risk for ischemic heart disease mortality increases steeply. So that's also true for stroke mortality. So my discussion is going to be based mainly on the cardiology guidelines for hypertension, the American College of Cardiology and the European Society of Cardiology guidelines on hypertension. So the American College of Cardiology has 4 categories to classify hypertension. Normal is below 120 systolic, and elevated is between 120 to 29 millimeter of mercury. And stage 1 hypertension is between 130 to 139, and stage 2 is blood pressure of greater than or equal to 140 millimeter of mercury. And the recently released European Society of Cardiology hypertension guideline, it's even simplified the classification further, and it has 3 categories. Then an elevated BP similar to that of the American College of Cardiology, which is less than 120/70, and elevated is between 120 to 139 systolic and 70 to 89 diastolic. And they have hypertension, a stage called hypertension, where the office blood pressure is greater than 140/90. So there used to be a significant difference between blood pressure thresholds and as well targets among these 2 societies, but nowadays they are aligning together. So this makes it easier for us to apply the guidelines during our clinical practice. Regarding the cardiovascular risk stratification, it was not part of the management in the previous guidelines, but recently both societies have endorsed the cardiovascular disease risk assessment in the management of patients with hypertension. The ESC guideline recommends the use of the SCORE2 risk score to stratify, to risk stratify patients with hypertension. And for older persons, they have another SCORE2 OP score, which is validated for the European population. And the ACCHA guideline uses the pooled cohort equation to estimate the 10-year risk of fatal and non-fatal cardiovascular disease events in adults between the age of 40 to 79 years of age. So we need our own score, which should be validated in our own population. So if a patient has hypertension and a condition with sufficient cardiovascular disease risk, there is no need to calculate the risk score. These are patients with already established clinical cardiovascular disease, CKDs, hypertension-mediated organ damage, diabetes, and so on. So the other new thing incorporated in these guidelines is to decide on starting treatment, initiating treatment for patients with elevated blood pressure or hypertension. The guidelines recommend that blood pressure is confirmed with out-of-office measurement, with either an ambulatory blood pressure measurement or with home-based blood pressure measurement. So ambulatory monitoring and home monitoring have their own advantages and disadvantages. Ambulatory monitoring and home monitoring, their major advantage is that they can both identify white coat and masked hypertension. So white coat hypertension is when patients are hypertensive in the office, but they have normal blood pressure out of the office. And masked hypertension is when patients have normal blood pressure measurements in the office, but increased blood pressure measurement out of the office. So both non-office blood pressure measurement techniques can identify these conditions. And ambulatory monitoring and also home monitoring, especially ambulatory monitoring, it measures blood pressure in the real life setting. There will be a nighttime reading, and it's also it gives also stronger prognostic evidence. It gives an abundant information, including short-term diurnal blood pressure variability, and also about nocturnal beeping, because it's going to read the nighttime blood pressure. The disadvantage is it's relatively expensive, and it can be uncomfortable and affect sleep because the blood pressure recordings are taken every 15 to 30 minutes. And with home monitoring, the patient himself is monitoring the blood pressure, so there might come up technical difficulties with measuring the blood pressure accurately, but it's easy. It's good to evaluate the longitudinal blood pressure measurement of the patient, because ambulatory monitoring is done only for 24 hours, but with home monitoring, the patient can do recordings for several days. The disadvantages, only static blood pressure at rest is measured, and potential due to error can be there, and nocturnal readings are not usually possible because patients most likely won't be encouraged to wake up from sleep and measure their blood pressure. So when we evaluate patients with hypertension, we have to go through their risk factors for hypertension. We have to look into their family and personal history of hypertension, cardiovascular disease, renal disease, smoking history, dietary history, physical inactivity, alcohol consumption, any psychosocial stress, and so on. And our history should target in identifying hypertensive-mediated organ damage and established cardiovascular diseases in the brain, eyes, heart, kidney, and peripheral arterial disease. And we should also look for clues for secondary hypertension. And in our physical examination, we have to look for the body mass index, the waist circumference, and signs of, again, hypertensive-mediated organ damage and established cardiovascular diseases, and signs for secondary hypertension. So these are the basic routine investigations that should be done in every patient who presents with hypertension. Fasting blood glucose, serum lipids are good to assess cardiovascular disease risk. Sodium, potassium, hemoglobin, hematocrit, calcium, and TSH are used to screen for secondary hypertension. Creatinine, urine albumin, 12-lead ECG are used to assess cardiovascular disease risk, as well as the presence of hypertensive-mediated target organ damage. Other optional tests include echo, the calcium coronary artery calcium scored by cardiac CT, troponin, ankle brachial index, and so on. These measurements are optional. They are used when they are going to change when we believe that they are going to change management. So echocardiography is in our country ordered right and left for every patient with hypertension, but the guidelines recommend that echocardiography should be done in patients, in hypertensive patients with ECG abnormalities or signs and symptoms of cardiac disease. So when we come to the preventing and treating elevated blood pressure and hypertension, the ultimate goal is to reduce the cardiovascular disease and to improve the quality of life and to prevent premature death. And besides blood pressure, other cardiovascular disease risk factors need to be comprehensively addressed. These are the non-pharmacologic interventions we can implement to prevent and treat hypertension. Weight loss, advice on weight loss is very important, since a decrease in every 1 kilogram of body weight is expected to decrease blood pressure by 1 millimeter of mercury. Healthy diet, especially the guidelines recommend the DASH dietary pattern, and the Europeans also recommend a Mediterranean diet, and the DASH diet is found to be more effective, and it involves consuming diet rich in fruits, vegetables, whole grains, and low-fat dairy products, and it's associated with 11 millimeter of mercury reduction in systolic blood pressure. Salt intake of less than 1,500 milligram per DL is recommended. It's associated with a 5 millimeter decrease in systolic blood pressure, and also a diet enriched with potassium is recommended by the guidelines. Physical activity in the form of aerobic exercise for about 150 minutes per week, 5 to 7 days of a week, is recommended. And also with the aerobic exercise, dynamic resistance and isometric resistance exercises also contribute in reducing the systolic blood pressure by about 5 millimeters of mercury. Moderation in alcohol. In the American guidelines, it's recommended to decrease the amount of to 2 drinks daily for men and to less than or equal to 1 drink to women. But this is difficult because the standard of drinks might differ between countries. So the recent European Society of Cardiology guideline recommends a maximum of 100 grams per week of alcohol, but that's the maximum, but the best result is obtained by avoiding alcohol altogether. And other than that, restriction of free sugar consumption and sugar sweetened beverages is recommended. And interestingly, caffeine was not found to, intake of caffeine was not found to increase cardiovascular disease in patients with hypertension. The other thing is stopping tobacco smoking, and also patients should be encouraged to maintain normal body mass index and normal waist circumference. These are the non-pharmacologic ways we can decrease the blood pressure level. When we come to the pharmacologic management of hypertension, we know that there's a clear relationship between the intensity of blood pressure lowering and the relative and absolute reduction in the risk of cardiovascular disease events for all adults, regardless of age, sex, prior cardiovascular disease. And the higher the patient's baseline absolute risk for cardiovascular disease, the greater the net benefit from BP lowering treatment. And at the population level, the lower the estimated number needed to treat. So this is a systematic review and meta-analysis of 69 randomized control trials. In these trials, we can see that with a 10 millimeter reduction in systolic blood pressure, there would be a significant 20% reduction of major cardiovascular events, coronary heart disease, stroke, heart failure, and all-cause mortality. This happens regardless of the presence of underlying cardiovascular disease or no cardiovascular disease, and this holds true also for all stages of blood pressure, hypertension. This meta-regression analysis of 48 trials shows that a reduction in systolic blood pressure is associated with a decrease in the hazard ratio of major cardiovascular diseases. So these are the trials which dealt with intensive versus routine standard treatment for hypertension. So the more the reduction in systolic blood pressure, the more the major cardiovascular events are reduced. And among these trials, SPRINT trial is a landmark trial, and this trial, the design was that patients with systolic blood pressure greater than or equal to 130 millimeter of mercury and at least 1 risk factors were randomized for intensive systolic blood pressure lowering or routine systolic blood pressure management. The intensive lowering group, in the intensive blood pressure lowering group, the target was less than 120 millimeter of mercury systolic, and in the routine group, the target was less than 40 millimeter of mercury, and patients were followed for 5 years, but this trial was stopped early because there was a significant reduction in the primary endpoints of myocardial infarction, acute coronary syndrome, stroke, heart failure, and death from cardiovascular causes in the intensive treatment group. The mean systolic pressure attained with the intensive systolic blood pressure lowering was 121 millimeter of mercury, and in the routine systolic blood pressure management group, the average blood pressure attained was 136, and this decrease in cardiovascular risk factors was majorly driven by a decrease in heart failure, death from cardiovascular causes, and death from any causes. So this SPRINT trial, it impacted the American College of Cardiology guidelines. After this result was published, the ACC updated their guidelines in 2017, and they included systolic blood pressure between 130 to 139 as stage 1 hypertension, and they incorporated cardiovascular disease risk stratification for 10-year risk of cardiovascular disease. And if this risk is greater than or equal to 10%, the patients were supposed to be treated with non-pharmacological, if this greater than 30%, they were supposed to be treated with pharmacological therapy with BP lowering medications plus lifestyle therapy. So this was the major change after the SPRINT trial. And recently, the European Society of Cardiology also, they incorporated this cardiovascular risk stratification component to their management of blood pressure. So for patients with elevated blood pressure, they recommended for the risks to be stratified, and with their score tool, if the risk is greater than 10%, patients are going to have a lifestyle measurement for 3 months, and if not, they're going to go through they are going to go to pharmacologic treatment. And this is what I said for patients with elevated blood pressure. If they have already an established cardiovascular disease or hypertensive mediated organ damage, there's no reason to calculate their 10-year risk. But if they don't have, we will calculate their risk for the cardiovascular risks over 10 years. And if that turns out to be greater than or equal to 10%, they will go for lifestyle for 3 months. And if that doesn't decrease the blood pressure to normal targets, then patients are going to pursue pharmacologic management. And for patients with a 10-year cardiovascular risk between 5% to less than 10%, further risk modifiers are going to be incorporated, like high-risk ethnicity, as in Southeast Asians, and other risks like HIV, autoimmune diseases, and so on, to modify the risk, and as well CAC score, troponin, and carotid artery, ultrasound, and so on are used to risk stratify patients in these groups. And if they turn out to be positive, then they join this group with lifestyle measurement for 3 months. And if blood pressure is not controlled, then they go for pharmacologic therapy. The ACC 2017 guideline recommends a target goal of less than 130/80 for every patient with hypertension on treatment, regardless of age or comorbidities. But ESC guidelines, in the previous guideline, their 2018 guideline, the target was 130 for most patients. systolic blood pressure of 130, but in their recent guidelines, they have decreased the target, and the target for antihypertensive treatment is about 120 to 129 systolic by 70 to 79 diastolic. So they have also brought down the target, and the paradigm is called the lower the better, but within reasons. So if a patient doesn't tolerate this low blood pressure, we can even target for a higher blood pressure. So regarding the medications used to treat hypertension, the major drug classes with robust evidence for blood pressure mediated reduction in cardiovascular events are the ACE inhibitors, the ARBs, the dihydropyridine calcium channel blockers, the diuretics, and the beta blockers. And the magnitude of blood pressure reduction achieved with these main classes of BP lowering medications is almost the same, and their cardiovascular outcomes is also almost comparable, except for beta blockers, which were found to have a lesser effect on preventing stroke. And the other classes of agents like alpha blockers, hydralazine, and so on, they don't have a compelling clinical outcome data, and also there's a concern about their adverse cardiovascular effects, so they are not first-line treatment for hypertension. And this is a systemic review and meta-analysis of 68 randomized controlled trials. So the major first-line agents, the ARBs, the ACE inhibitors, the beta blockers, the calcium channel blockers, and the diuretics, they have similar cardiovascular outcome when compared to each other. But beta blockers appear to be inferior in their preventing major cardiovascular events, and as well preventing stroke, and as well preventing renal failure and all-cause mortality. While calcium channel blockers were found to be inferior to their group regarding the prevention of heart failure, and diuretics are found to be superior in their group. Calcium channel blockers are superior with their comparators with regards to decreasing the risk of stroke. So among all blood pressure lowering agents, these medications we just mentioned, ACE inhibitors, ARBs, dihydropyridine calcium channel blockers, and diuretics, are given a class 1A indication, and they're the first line antihypertensive agents, but beta blockers are recommended to be started when there are compelling indications like heart failure, MI, angina, atrial fib, and so on. So this is like the choice of starting blood pressure lowering treatment depending on comorbidities. For F patients, we might want to use beta blockers. For heart failure, we give priority to the ACN, ARBs, MRAs, beta blockers, diuretics. For chronic kidney disease, especially if they have proteinuria, we go for ACE inhibitors and ARBs. So the other thing that's emphasized on the guidelines is about initiating antihypertensive treatment with combination with drugs. So combining drugs from different drug classes can have additive or synergistic effect. It's hypothesized that since drugs from different classes use different mechanism of action, they can be more effective in reducing blood pressure. And if combination of BP lowering therapy is pursued, a single pill combination is preferred. So these are analysis of 354 randomized trials. And as you can see, the average fall in blood pressure in systolic and diastolic blood pressure with two drug combinations is almost additive to separate two drug monotherapies. And as well regarding triple drug, the blood pressure reduction is more is greater with 3 drugs as compared to 2 drugs, and 2 drugs is better than 1 drug therapy. And regarding effects of blood pressure in lowering incidence of stroke and ischemic heart disease, 3 drugs bring about a lower cardiovascular disease risk reduction as compared to 2 drugs, and 2 drugs are better than 1 drug. And the other concern was when we combine medications, the risk for if adverse drug reactions might be prominent, but this was not the case, this meta-analysis. So the adverse effects were significantly lower than the values expected with an additive effect. And it was found out that 1 drug does not therefore potentiate the adverse effect of another. So side effects were not additive as was expected with combination treatment. So this is the ESC 2024. So unless patients have elevated blood pressure, or not hypertension, but elevated blood pressure, unless they have moderate to severe frailty, or unless they have symptomatic orthostatic hypotension or age greater than or equal to 85 years, drugs should be initiated in combination. So low dose double combination therapy using the first line agents has a class 1 indication. And if the blood pressure is not controlled in 1 to 3 months, then a low dose triple combination is pursued. If blood pressure is not controlled with this triple therapy, then maximal tolerated triple combination therapy is recommended. If blood pressure is not controlled with this regimen, then resistant hypertension is likely. So patients are investigated for possible resistant hypertension and spironolactone, and the other second line agents can come in this scenario. And beta blockers can be added if there is compelling indication in any stage of the follow-up. The ACC 2017 recommends initiating blood pressure lowering agents in combination for patients with stage 2 hypertension and an average blood pressure more than 20 by 10 millimeter of mercury above their target blood pressure. So in conclusion, cardiovascular disease risk begins below thresholds used to define hypertension, and the risk increases with higher blood pressure levels, and BP lowering can significantly reduce major cardiovascular outcomes. The major drug classes with robust evidence for BP-mediated reduction in cardiovascular disease events should be used as first-line agents, and combining drugs from different drug classes can have additive or synergistic effects and lead to greater BP reduction with low adverse drug effect, and the lower the blood pressure target, the better. Thank you.
Okay, thank you, everyone. So we have a couple of questions online. The first question reads, is nifedipine recommended drug to use for hypertension treatment in our country? Is it, the effect is predictable?
So we can use nifedipine as an antihypertensive drug in our country. It's cheaper, but usually we have to go for longer acting drugs when possible for purpose of adherence. So we have amlodipine, which is given once daily. So we usually nowadays go for longer acting calcium channel blocker, dihydropyridine calcium channel blocker than a twice daily dosing.
What are the drawbacks of SPRINT trial compared to other trials?
Actually, the way the blood pressure was taken in SPRINT trial was criticized because they used an automated BP measuring device, and patients were left in a quiet room before their blood pressure was taken. So it was criticized that this doesn't happen in a real-time setting. So the way they determine the way they measured their blood pressure was not comparable to real-time settings. So that was one of the criticism sprint trial got, but actually it was a paradigm shifting trial because the American College of Cardiology updated their BP targets as well as threshold for treatment after the publication of the sprint trial. And also the Europeans followed later.
Okay, thank you very much. The next question reads, which cutoff should be taken to diagnose hypertension? So should we use the ESC or ACC since we're short on local data?
Yeah, so those guidelines can be used. They are almost aligning together this time. So whenever we're thinking of a patient to have elevated blood pressure, like between 120 to 139 systolic blood pressure, then we go for risk stratification. So we can, you know, when the blood pressure increases, the cardiovascular disease risk also increases. But with a lower blood pressure, we have to risk stratify in order to select the kind of patients who would benefit from blood pressure treatment. So we, both guidelines, I think we can, they are aligning together, so we can use either of them.
Thank you very much. The next question reads, is there a study done on Ethiopian patients comparing the cardiovascular and blood pressure reduction effects of the various classes of antihypertensive drugs?
I'm not aware of that, sorry, can't answer this question.
Okay, thank you.
But it should be done, yes, it should be done, and the risk score also should be developed, which is going to be validated to our population. And one thing I forgot to mention during my presentation is that we have to use a validated blood pressure measuring apparatus. That's what the guidelines recommend. There is a site called www.validatebp.com. So those are the blood pressure apparatus which are recommended to be used by the guidelines. So every blood pressure apparatus is not recommended to be used.
Okay, thank you. So the last question we have so far reads, which drugs have better outcomes in hypertensive emergencies?
Okay, I didn't discuss the hypertensive emergency drugs, but these are just short-term medications. So we can use, especially in our setup where there is shortage of IV drugs, especially to which should be used for hypertensive emergency cases. We use whatever is available. We have labetalol occasionally. We can use hydralazine, and also we can use metoprolol IV in our setup. So I'm not aware of the cardiovascular outcomes with this emergency drugs, but for hypertensive emergency, we use whatever is available in our setup.
Okay, thank you very much. Another question popped up. So it reads, what do you think of adding hydrochlorothiazide for calcium channel blockers induced edema?
I don't think it works. I don't think it works. This is due to the vasodilatory effect. The edema is one, it's dose dependent, and it's more common in women. And with decreasing the blood pressure, we can minimize the occurrence of the edema. There was one hypothesis that combining these medications with ARBs or ARNIs might decrease the edema, but I didn't see that happening in my clinical practice. So we can reduce the dose of the leg edema, and it's more about counseling patients, because patients are concerned about their leg swelling, thinking that they have some heart failure or some renal issues. Usually that's what they come with, you know, they are worried that these organs are affected. That's why they're having leg edema. So reassurance is the best way to go. Reassurance that this leg edema is just showing the vasodilatory effect of the drug and that it's working, and it's not affecting their kidneys or the heart in any way. So that usually works. You know, if it's very significant, we can move them to another antihypertensive agent and even decrease the dose and see the effect. But usually with the insurance, they get used to it and they don't complain that much.
Okay, thank you very much. These are all the questions we heard from our virtual attendees.
Thank you.
Thank you everyone for attending thus far. We're very glad to have you with us. Thank you.